Greetings, dear learner. We were learning the metallic poisons. Up till now, we covered up to the iron poisoning. Today, we shall move ahead, but before going ahead, I have a case with you. Based on the case history, you have to guess what is the today's topic. So here we begins. A 48-year-old Indian male working in the silver jewelry industry since past 15 years, non-smoker with a history of progressive worsening skeletal pain over the 5 years. On his X-ray, it revealed the reduced bone density and prominent trabecular markings in the lumbosacral spine and the hip region. Dual X-ray absorptiometry confirmed the severe osteoporosis, that is T score less than minus 0.25. Impaired renal function showcased by the elevated serum creatinine and the urea level. Mild normochromic normocytic anemia with hemoglobin at 9.9 gram per deciliter was present. Hypophosphatemia, hypouricemia and elevated alkaline phosphatase with normal liver function and the electrolyte level was the findings. Further, parathyroid hormone was elevated with normal serum vitamin D levels. Urine analysis revealed trace albumin and presence of glucose on urine dipstick despite normal plasma glucose level. Elevated fractional excretion of uric acid and phosphatase was there. Increased urine protein with creatinine ratio and albumin creatinine ratio was present. Now, can you tell the diagnosis in this patient? Here, the presence of hyperuricosuria, phosphaturia, and the renal glycosuria is suggestive of Fanconi syndrome. Here, important to note is that patient is working in the silver jewelry industry. Silver jewelry industry is the potential site for exposure of cadmium compound. So, the poison is cadmium. On blood examination of the patient for the cadmium, it revealed grossly elevated cadmium concentration, that is 3736 nanomole per liter, while the normal range for in case of non-smoker is 27 to 106 nanomole per liter, and in case of smoker it is 4 to 424 nanomole per liter. So, very high elevated level of the cadmium was present in his blood. This confirmed the diagnosis of cadmium toxicity. Urine cadmium in the patient was 75 microgram per gram, while the normal range is 0.5 to 3 microgram per gram, suggesting the chronic exposure of the cadmium. Both blood and urine cadmium were measured using the atomic absorption spectrophotometry. Cadmium is widely used in the silver jewelry industries. Silver is mixed with cadmium and the alloy is used to make silver jewelry. In the process, cadmium fumes are released that contribute to the toxicity. So, in this patient, this toxicity occurred from these fumes. So, by now you would have understood our topic today is cadmium. You can see cadmium in its metallic form. Cadmium exposure is a serious concern for the workers in the industries like zinc smelting, battery manufacturing and the silver jewelry production, especially in the developing countries. It can also occur through contaminated foods, tobacco smoke and environmental pollution. Chronic cadmium toxicity mainly affects the kidneys and the bones, leading to the conditions such as Itai-Itai disease characterized by painful osteoporosis. Even minimal exposure can cause skeletal demineralization due to impaired bone cell function and interaction with the vitamin D3. So, the mechanism of action is the skeletal demineralization. Cadmium, once absorbed into the bloodstream, accumulates in the tissues, particularly the kidneys, causing renal dysfunction and conditions like that of the acquired Fanconi syndrome. Diagnosis mainly relies on the clinical suspicion, occupational history and the specific tests like urinary protein analysis and the blood cadmium level. Treatment option is limited, but the main focus of the treatment is preventing further exposure and managing the symptoms. Chelating agent like calcium sodium editate and DMSA succimer is seen to be of benefit. Then Itai-Itai disease is the one of the chronic presentation in case of the cadmium toxicity. This is the classical example of the cadmium toxicity by the environmental exposure. The disease was endemic in the Jinju River basin in the Toyama region in Japan as a result of the environmental pollution of the cadmium, a byproduct of the zinc mining in that region. Itai-Itai is a Japanese name, means the ouch ouch, indicating painful osteoporosis resulting from the chronic cadmium toxicity. So, there is the osteoporosis you can see in the picture. Osteoporosis is occurring in the patient and he is not able to stand. The various bony changes are seen in the patient. Then the management of the Itai-Itai disease or the cadmium toxicity lies with the diagnosis first. For the diagnosis, blood cadmium level normally it is 0.1 to 1 microgram per liter, and in a smokers it is 1.4 to 4 microgram per liter. So, if it is elevated, then it is indicative of cadmium toxicity. Urinary cadmium excretion, if it exceeds 2 microgram per 24 hour or 10 microgram per liter, is potentially a nephrotoxic. Then radiography in case of acute inhalational exposure may show diffuse pulmonary edema, later progressing to the bronchopneumonia. Chronic poisoning characteristic includes the osteomalacia and the multiple fractures. X-ray fluorescence can detect the kidney cadmium level. Then for the treatment, the chelation therapy that is done through the calcium sodium EDTA and the DMSA succimer for the acute poisoning. BAL is contraindicated due to potential nephrotoxicity. Dose of the calcium sodium EDTA is 75 mg per kg 24 hours, deep intramuscular or slow intravenously, given 3 to 6 divided doses for up to 5 days. Succimer is given initial dose of 10 mg per kg orally every 8 hourly for 5 days and then every 12 hourly for next 14 days. Hemoperfusion is ineffective due to the high cadmium plasma protein and the red cell binding. In case of chronic cadmium toxicity, chelation therapy is not recommended. Removal from exposure and supportive treatment are advised. Reason being that redistribution of cadmium through the chelation may worsen the toxicity. So, we covered arsenic, lead, mercury, copper, iron and the cadmium. The last one remaining is the thallium poisoning. We already discussed a case of thallium poisoning at the start of this course, in which a son-in-law poisoned his father-in-law, mother-in-law and wife with the chronic thallium by mixing it in their food items. Thallium is a soft, pliable metal which is acquiring an increasingly notorious reputation as an ideal homicidal poison. Back in early 19th century, thallium salts were the quite multitaskers. They were used for everything from the hair removal to treating the serious ailments like syphilis, gonorrhea, tuberculosis and even scalp ringworm. However, the doses given were often dangerously close to causing severe poisoning. Thallium sulfate, being the odorless and the tasteless, found its way into the rodent control market, sold under the various brand names like the Thalgran and the Martin's Rat Stop. It was also unfortunately popular for more nefarious purpose, often used as deadly poison. Thallium acetate, originally intended to treat the tuberculosis symptoms like night sweats, took an unexpected turn and used for the homicidal purposes. Its use for treating tinea led to unintended hair loss. Eventually, its potential toxicity led to its abandonment. Beyond its medicinal usage, thallium found its way into the various industries like the electronics industries, pharmaceutical, glass manufacturing and even infrared detectors all have the stake in the thallium, with electronic accounting for a significant chunk of its production. Then we should know how it acts on the body. Thallium, being a cellular toxin, behaves similar to the potassium and distributes intracellularly across all the body tissues. However, its distribution undergoes change over the time. Thallium acts differently depending on its concentrations. At low level, it substitutes potassium in the sodium-potassium ATPase PAM. At high level, it competitively inhibits the sodium-potassium ATPase pump. Thallium also displays an affinity for the sulfhydryl group. Thallium disrupts the sulfhydryl cross-linking in keratin, leading to alopecia, that is hair loss, abnormalities in the nail growth known as Mees line. Fatal dose of the thallium is about 12 to 15 mg per kg. In adults, the reported fatal dose is approximately 1 gram of the absorbed thallium. Fatal period is 24 to 36 hours after the injection of fatal dose. Then the presentation in case with the acute poisoning of the thallium. Initial patient begins with the abdominal pain, gastroenteritis, sometimes with the hematemesis and hematochezia, tachycardia and the headache, followed by the confusion, paresthesia, hallucination, convulsions, retrobulbar neuritis, ophthalmoplegia. Death typically occurs due to the respiratory failures. The potential complications with the thallium poisoning are the hepatic and the renal failure that may occur in some cases. Bone marrow depression is also the possibility with the acute thallium toxicity. Characteristic sign seen in the acute poisoning is a distinct dark pigmented band that may develop on the scalp hair within 3 to 4 days of the acute toxicity. Then the first voided urine after the ingestion may show the green discoloration that may be indicative of the thallium toxicity. You can see here in the table a time scale of likely signs and symptoms that occur chronologically. When it is less than 24 hours, the patient presents with a nausea, vomiting, GI bleeding, usually after ingestion. 0 to 4 days, the pancreatic, parotid damage, chest pain, constipation. Up to 7 days, acne, confusion, delirium, organ failures. 14 days, peripheral sensorineuropathy, ocular nerve paralysis, cardiac features like disturbances in the blood pressure and the pulses may be seen. And the late feature is the alopecia. You can see here the picture of alopecia seen in case of the poisoning with the thallium. Then in case of the chronic poisoning, alopecia is the pathognomic sign of the chronic thallium poisoning. Typically begins about 10 days after the initial dose. It may lead to the total scalp hair loss within a month if intake continues. Lateral halves of the eyebrows are also affected. Hair regrowth is possible if the patient survives of the poisoning. The patient may present with the skin rash, that is papillomacular rash, often in the butterfly distribution on the face, may accompany with the acneiform eruptions. The nail dystrophy along with the Mees line may be seen. As you can see in the picture, the nail dystrophy in the patients with the thallium poisoning. Nails show ridges, Mees stripes and erosion of the proximal parts. Painful ascending peripheral sensory motor neuropathy may be there. Profound pain, paresthesia, especially in the lower limbs and the soles are the presentation. That is also known as burning feet syndrome. Loss of pain, temperature, vibratory and position sense. Unsteady gait may develop, prohibiting walking. Ataxia in the patients, that is impaired in coordination. Other neurological manifestation that may include the cranial nerve palsies, optic neuropathy, tremor, encephalopathy, psychotic behaviors may also be observed. Certain ophthalmological manifestation with the thallium poisoning are the ptosis, ophthalmoplegia, nystagmus, keratitis, lens opacities and optic atrophy. Functional changes include abnormal color vision, impaired visual acuity and central scotomas. Then under the cardiovascular and hematological manifestation with the chronic thallium poisoning, hypertensive cardiomyopathy, ECG changes, leukocytosis, thrombocytopenia, cardiac arrhythmias, bradycardia and T-wave abnormalities are reported. Several cases may result in refractory cardiogenic shock. Other signs and symptoms that are of importance are autonomic dysfunction, testicular toxicity, hypokalemia, renal failure, hepatic dysfunction. Bluish line in the gums may appear 3 to 4 weeks post-injection. Respiratory failure is common in severe motor neuropathy cases requiring prolonged ventilatory support. Then the thallium triad is the important diagnostic feature of the thallium toxicity that includes the combination of alopecia, skin rash, painful peripheral neuropathy and mental confusion with lethargy that raises the suspicion of the chronic thallium poisoning. High suspicion is warranted in patients with the painful ascending peripheral neuropathy and the gastrointestinal symptoms appearing much earlier than the alopecia. Symptoms may mimic other conditions like Guillain-Barré syndrome, acute porphyria, psychosis and thiamine deficiency, so that this becomes the agent of the ideal homicidal poison as it mimics the natural diseases. We discussed this when we were talking about the case of the thallium poisoning. Then for the diagnosis of the thallium poisoning, X-ray has to be done. It may detect opacity in the gastrointestinal tract or the liver. Vision test may assess the contrast sensitivity and the color vision for early detection of the optic neuropathy. EEG and the nerve conduction studies, abnormal EEG pattern and delays peripheral nerve conduction may be observed with the peripheral neuropathies. Hair microscopy may reveal the characteristic black pigmentation of the hair roots. Urine test may be applied as a bedside test. Under that, mix the urine with the specific reagents to produce the fluorescent colors. A bright yellow or the fluorescent red color indicates the positive result. For this, the reagents that are used are the bromine solution that is formed by the sodium bromide dissolved in the water with the HCl and the liquid bromine. Another reagent is the sulfosalicylic acid, that is the saturated sulfosalicylic acid mixed with the HCl. Then another diagnostic method is the atomic absorption spectroscopy. Then important diagnosis and confirmation is done by the measuring the level of the thallium in the biological samples, that is done by the atomic absorption spectroscopy. Then urine thallium excretion, that is the excretion of thallium exceeding 10 to 20 milligram in 24 hours is of diagnostic value. Whole blood thallium level over 100 microgram per deciliter suggests the potential poisoning. Then the monitoring of the calcium levels shall be done for the management purpose as well and for the diagnosis as well. Hypocalcemia may occur during the acute phase of the thallium poisoning, necessitating calcium level monitoring. For the treatment of the thallium poisoning, the best agent is the Prussian blue. A stomach wash with Prussian blue of a crucial value. Prussian blue, that is potassium ferric ferrocyanide, prevents the thallium absorption by binding with it, exchanging potassium for the thallium in its crystal lattice network. It is administered through a duodenal tube at a dose of 125 mg per kg twice a day with the 50 milliliter of 15% mannitol until the urinary excretion falls below 0.5 mg per day. Multiple doses of activated charcoal may aid in the thallium elimination by interrupting its intrahepatic circulation. Then the forced diuresis with potassium chloride may also be tried. Potassium chloride therapy in conjunction with the forced diuresis may enhance thallium excretion, although its effectiveness is not very certain. Hemodialysis and hemoperfusion can effectively remove the significant amounts of thallium from the blood. And the traditional chelating agents like the British anti-leukocyte, EDTA, have not been very effective in the treatment of the thallium poisoning. Diethyl carb, that is diethyl thiocarbamate, previously used as an antidote, dithiocarbamate may worsen the patient's condition and is no more recommended today. Physiotherapy helps to prevent muscle contracture caused by the thallium toxicity. Shaving the patient's head may elevate the psychological stress of the hair loss. Proper oral hygiene is crucial to prevent severe stomatitis. If treatment is initiated promptly, recovery from thallium poisoning is typical, although it may require prolonged period. However, residual effects such as amnesia, ataxia, tremor and foot drop may persist even after the complete treatment. In this way, the treatment of the thallium poisoning cases are done. Then in case of death of the person, to diagnose, we may look for the clinical manifestations in the patients like the alopecia, stomatitis, fatty degeneration of the heart with tabby cat striation of the ventricle as can be seen in the picture. The cardiac muscles are replaced by the fatty tissues. Then fatty degeneration of the liver can occur, renal damages, pulmonary edema may be seen, cerebral edema with widespread degeneration of the nerve cell and axons may be finding. However, these findings are not specific. They are only suggestive for the thallium poisoning, and confirmation of the thallium toxicity can only be done with the help of the toxicological analysis report, and thereafter the opinion for the thallium toxicity shall be given. In this way, the postmortem in case of thallium toxicity shall be done. With this, we finishes all the aspects related to the metallic poisons. Although metallic poison is a very long list, apart from these certain poisons that I discussed, many other minor metals that they also can cause toxicity to the body, and they are presented rarely in different scenarios. Thank you for your patient listening and best wishes for your future. Thank you.